I'm the first speaker. So I wanted to share with you some thoughts that I have about where we are and where we're going in HIV prevention. I have for many years started out a lot of my talks with this slide to provide context for the growing population of people with HIV who we've been targeting in our work for some time for adherence and sexual behavior change risk reduction interventions. And I think it's really that framework that has brought us to the point where people can actually talk about cures and reducing incidence to a low point to where we can actually get to zero infections. I think that there is a reality there. I think that there's a particular reality in perinatal infections. There shouldn't be a baby born in the world with HIV infection. We know how to do that. And in a lot of places like New York State, we are doing that. So, I think it's a reasonable discussion to have, but it all hinges on incidence, not prevalence, not number of people living with HIV. And it's this, in this country, this stubborn annual incidence rate that is driving people in Atlanta at the CDC fairly crazy. It is happening in the context of the scale-up of antiretroviral therapy. And so the focus of HIV prevention now has become antiretroviral therapy, and that's what I'm going to mostly talk about today. But we have to bear a couple things in mind. HIV prevention has always been biomedical, and biomedical prevention never has really achieved any of its potential, right? So we know that condoms and microbicides potentially, possibly, maybe, in some form, female condoms and now antiretroviral therapy, because of behavior, society, social forces, and contextual factors, they never achieve their optimal preventive value. The only things that could are male circumcision, which is having a significantly poor uptake in a lot of places in Africa, and it is not nearly as protective as some of these other technologies. But because it doesn't rely on behavior other than getting circumcised, it's kind of like a vaccine, which we don't have. And I won't talk about it all today because vaccines are unicorns in HIV. So when we talk about HIV prevention, when I talk about HIV prevention, I always want to remember that it's always been biomedical. Condoms are a biomedical device. Syringes are a biomedical device. HIV testing is a biomedical device. What could be more medical than diagnostics? But we don't think about them that way anymore. We think about them as behavioral interventions. We think about testing and counseling. We think about harm reduction. And we think about getting people to use condoms. Biomedical technologies morph into behavioral interventions when they're scaled up. That's a reality. So what is the future of HIV treatment as prevention then? Well, we know that when antiretroviral therapy is administered under specific conditions, it substantially reduces HIV replication. That's how it works, right? Throughout the body, in all of the compartments of the immune system. So the genital tract can become non-infectious under certain conditions of antiretroviral therapy. Now, Vernanza showed this more than a decade ago, that men in Switzerland who were treated with antiretroviral therapy were suppressed, their viral load was suppressed, who were checked every 6 months for sexually transmitted infections, aggressively tested and treated for STIs. These men were really non-infectious. And it led the Swiss Health Ministry to proclaim that if people met those conditions, they could be considered non-infectious. And this Swiss statement was a bold move that came before definitive, what I would consider really definitive proof, that in fact it is true that under certain conditions, those conditions that Vernanza tested in his lab, could result in people being sexually non-infectious. Now, it was controversial when the Swiss did this, but I don't believe it's controversial anymore because of HPTN 052. So now we have a very well-conducted randomized clinical trial that you'd have to be a true denialist to deny the impact of antiretroviral therapy in HPTN 052. So this brilliant study by Mike Cohen is definitive as far as I'm concerned. So in HPTN 052, there are 39 HIV infections in people that were not treated early with antiretroviral therapy, and they all occurred in those people that were not treated early with antiretroviral therapy. Only one infection, and these were genetically linked. I mean, this is, you'd have to be Peter Duesberg to deny this. Now, important facets of HPTN 052. These were stable coupled relationships. These people adhered very carefully to their medications. If you ask Mike Cohen about it, he tells you that if they got wind of anyone not taking their drugs in the early treatment group, they went out and found them and made them take their drugs. The adherence was premium in that study. These people had clinical visits every 6 months. Their partners came in with them every year, and they were very carefully, aggressively treated and tested for STIs. But what are we currently seeing as HIV treatment is being increasingly accessible and scaled up throughout the world? Let's look at sort of the best case scenarios in countries where people are tested, where people have access, where people are being treated. Australia is a pretty good example. Okay, so in Australia, they have a very good healthcare system. People have access to treatment, and they're treating more and more people every year. Access is going up in Australia. Viral suppression is going up in Australia too, and so are CD4 counts. So the fruits of antiretroviral therapy are being seen in the health of the Australian population living with HIV, and that is primarily men who have sex with men. But we're also seeing in Australia increases in sexual risk behavior, and sexually transmitted infections are paralleling that, and so HIV incidence is going up as number of AIDS diagnoses is going down. And this is not just being seen in Australia. So if you look at the UK, you look at Germany, you look at France, you look at Belgium, you look at Canada, and you look here at home, you see the same thing. Okay? HIV infection rates among men who have sex with men are going up. Now, how do you explain this in the context of antiretroviral therapy? Now, I have to say that it is arguable that incidence in this country among MSM may not be changing as much as some people think it is. It's a point that's being debated. But in a brilliant paper published in a pretty good journal, Ron Stahl told us in AIDS and Behavior, and probably what could be the best title of a paper ever running in place, that if you just assume that incidence isn't going up each year, if you just accept the unacceptable high incidence rate of 2.4 incidence among MSM, 4% incidence among African American MSM, if you just assume those sort of lower bound estimates, and you have a cohort of young men who have sex with men who enter this cohort at the age of 18, by the time the black men are 40, nearly 60% of them will be HIV infected. Stahl calls it sobering, and then he calls it scary. Everyone should download that paper today. Downloads count. So what explains this increased incidence in HIV in the face of antiretroviral therapy? Well, not everyone meets the Swiss ideal, and that's really the bottom line. In a study that we did that was generously funded by the National Institute of Alcoholism, Alcohol Abuse, drinkers, those people, we had a cohort of people who were drinking alcohol and taking antiretroviral therapy, and we wanted to see over time, we wanted to see what did these folks look like in terms of this, and these are people living with HIV in Atlanta. They're pretty typical, I think, of the Atlanta population of folks living with HIV infection. We had 170 HIV positive drinkers on ART. We followed them for 9 months. And we saw that, in fact, many of them, most of them, did not meet the Swiss ideal. right? So 23% of these people were not virally suppressed. A quarter of them had had an STI diagnosis in the previous 3 months. And what we saw in those people was high rates of sexual risk behavior as well. So these people in red are very likely quite infectious. Even those that are virally suppressed in their blood plasma are very likely infectious for those that have co-occurring STI. So in this context then, how will HIV treatment used as prevention fail? Well, I think there are 4 things that doom it if we don't deal with these things. Health disparities, poor adherence, risk compensation beliefs, and co-occurring STIs. In health disparities, there's the cascade. And everybody knows the cascade, everybody talks about the cascade. Cascade is actually a very nice framework for thinking about access to care in this country. We all should know that it's not exactly right. It's based on a bunch of different reviews. It doesn't like represent sort of, these aren't the same people in the same places at the same time. I walked up to Gardner at the Miami AIDS conference and AIDS adherence conference that NIMH does, and I said to him, so it's not like really that bad, right? And he looked at me and said, no, it's not that bad, but it's a nice framework. And I think that that's the best way to think about it. Everyone who should be treated isn't being treated, and everyone who's being treated isn't adhering. Now, when you look at health disparities, in Atlanta, we see a lot of food insecurity, people that don't have enough to eat on any given day. This really is a significant problem in our population, and we know that it is predictive of poor adherence to antiretroviral therapy. We've done about a half a dozen studies on this. Sherry Weiser at UCSF is the real leader in this area, and she sees the same thing in San Francisco and in Vancouver. In major cities in this country, poor people don't have food to eat when they're HIV infected or have other chronic illnesses. They're not managed well. And so these are data from our unannounced home-based pill counts that we do on the phone. And so they're very valid. I put my life behind these data. I trust them quite literally with my life. And so these are really good adherence data. And we see on a monthly basis over the course of a year in this particular cohort, we see every single month people that don't have sufficient food missing their medications significantly more than people who don't. And by the way, those adherent people, those more adherent people in the green, they're not so great, right? On average, they're below 90% adherent. They're probably right on the line of sufficient adherence for viral suppression. But the people that are really struggling and are food insecure, much worse off. Medication adherence itself is associated with risk behavior. We've seen this in multiple studies. This is again unannounced pill count data from a different study. And we fairly consistently see people who are non-adherent to their medications also engaging in more unprotected sexual acts with uninfected partners. And this is not a mystery why. The drivers of both of those behaviors are the same, particularly alcohol, drug abuse, and mental health issues. And they're different things. The most prevalent of these in our population is alcohol abuse. And alcohol abuse, we put this model forward some time ago. Alcohol use and drug use and mental illness drive sexual risk practices in people with HIV and non-adherence. So these people are unsuppressed. They're more likely to contract genital tract inflammation causing pathogens, which increases infectiousness. They ain't in Switzerland, folks. They're in Atlanta. Infectivity beliefs and risk compensation are real. Now, they're debatable in some things. In PrEP, for example, there's a big debate about whether risk compensation will occur. I think that's an open question. But when it comes to antiretroviral therapy and beliefs about non-infectiousness and beliefs about suppression, these are real beliefs. I should have actually started this talk out by having you raise your hands if you believe that if a person's on antiretroviral therapy and they have an undetectable viral load in their blood, they're non-infectious or less infectious sexually. How many would you raise your hand?
Depends on how you say that, non or less.
Well, I've kind of screwed up. I blew my thunder. I should have asked you first because I think everyone believes that. I think everyone believes it. Why wouldn't that belief impact behavior? Well, we all know the primary motivation in sexual behavior is to not use a condom. We have a device that prevents HIV infections. What all of this is about is people don't want to use condoms. That's what this is all about, right? If people just would use condoms, we wouldn't be standing here talking. People don't want to use them. So we got to have pills and all this other stuff. And so when people believe that they're less infectious, they're not going to use condoms. It's the point. Now, when people have an undetectable viral load, but they don't hold the belief that they're less infectious, that relationship isn't there. This is a meta-analysis published a while back by Krepes and other folks at CDC. And it showed that there really isn't a relationship between an individual's viral load and their use of condoms and risk behavior, negative and positive people. But when they hold the belief, every study finds that association. And every study since this meta-analysis finds that association. In a study that we did a while back, we followed a short-term cohort of people, and we watched as a small number of people, 16 people, right, and represented in this red bar, went from having from having a detectable viral load to an undetectable viral load over like 9 months. The black bar is a couple hundred people whose viral load either didn't change or got better, or got worse rather. They started out undetectable and became detectable. But those 16 people whose viral load went to undetectable, back in like 2000, their rates of unprotected sex went off the ceiling. In health behavior research, this is called permission. I was reading about it this morning, about sodium. Okay, I'm more interested in weight loss right now than I am HIV. But I'm going to tell you, just my personal weight loss. But the thing that health behavior researchers call this is permission. If you buy Doritos that are low sodium, you'll eat a bag of them because it gives you permission. If you have an undetectable viral load, it gives you permission not to use a condom. It just makes sense. But what's going to really do treatment as prevention and STIs, and all these things kind of lead up to infectiousness, right? So we know that in RCI and serodiscordant couples who were together forever and were closely monitored by Maria Weber and Ron Gray, and were in this carefully controlled environment, and were untreated, right? We know that HIV infections in RCI were occurring when people's viral load was higher. And we know from that very good science that viral load in blood under those conditions is related to infectiousness, is related to transmission risk. It is what set the stage for HPTN-052. But when you look at the studies that have correlated blood viral load with viral load in semen in HIV-infected men, we counted 19 of these studies a few years back. And we just looked at the correlations that those studies reported. There were two outliers in that literature. One of them was a study that we did in Atlanta. We had contemporaneous blood draws and semen donations from 44 HIV-infected men. Some of them were treated, some of them weren't treated, some were adherent, some of them weren't adherent. They were basically HIV-positive guys off the street. We had a zero correlation, okay? There was no relationship between the viral load that we saw in their semen and the viral load that we saw in their blood. It was zero. The other outlier is Vernanza, right? The Vernanza study I referred to earlier, where every man that was undetectable in his blood was also undetectable in his semen. He had a perfect correlation. Every other study, the other 17, fell between a range of 0.2 and 0.6 correlation. The average is 0.44. That means that a guy who's undetectable in his blood or not, knowing his viral load in his blood accounts for about 16% of the variance of what he can know about his true sexual infectiousness. That is not good. What accounts for that? Genital tract inflammation, which isn't just STIs. Cohen and Pilcher told us this so many years ago, that every time a person with HIV infection has a genital tract infection, it's like a new mini acute infection. They're highly infectious, even if they're undetectable in their blood. When you look at co-occurring STI and HIV in studies throughout the world, we reviewed about 38 of these studies, you see quite high prevalence of sexually transmitted infections in people living with HIV. Co-infections in the genital tract are highly common in populations living with HIV across the world. So in this sort of daunting circumstance, as I see it, what can we do for treatment as prevention to succeed? The really good news is we know exactly what to do. I mean, it's not like there's any mystery here at all. We do what HPTN-052 did. We need to aggressively recruit patients. The CDC is doing that. They're testing everyone a few times a day. I don't know if you've been tested for HIV today, but I think Dave Purcell tests you. He carries these kits around with him. This is what the CDC is, the Center for HIV Testing. I mean, so we're doing that. We're trying to detect every single person. So that is scaled up as far as I can tell in this country. And we need to monitor and intervene for optimal adherence. I'm not so sure. We have to educate about the realities of infectiousness. We can't let people walk around thinking they're always non-infectious unless they really are. And sometimes they will be. We have to counsel against risk compensation, and we have to aggressively test and treat STIs. Now, if you ever read the HPTN-052 protocol, you have way too much time on your hands. Now, I have read it. The word counseling appears on 33 pages of this 150-page document. It talks about risk reduction counseling for the individuals and the couples throughout the study every year. It talks about adherence counseling at each study visit, and a very aggressive approach to making sure that people who were non-adherent were adherent. It did risk compensation counseling, although it did not call it that. Every patient in HPTN-052 was told, now we don't really know if antiretroviral therapy is actually going to prevent HIV infections. That's why we're doing this study. That's what it's about. We don't really know that. So the person walks out of counseling going, well, I can continue to roll the dice, or I can continue to practice safer sex, or maybe a little less, or maybe a little more. But they weren't definitively told, now you're taking antiretroviral therapy, you've been undetectable for 6 months, you don't have an STI, your uninfected partner doesn't have to worry. That's what the Swiss would have told them. Right? That's not what they were told in HPTN-052. And in HPTN-052, thank God, the PI was Mike Cohen, these people were very carefully monitored and intervened for genital tract infections. That's why HPTN-052 worked. It wasn't just the pill. Okay? And so we have a biomedical technology. The question is, how will it morph into a behavioral intervention? That's the question. Now the good news also is that we have a whole bunch of intervention technologies that have been available for some time that can help with this. We have a bunch of adherence interventions, and meta-analyses show they can really work. We have a bunch of risk reduction counseling interventions for people living with HIV. Meta-analyses show they can really work. And we have a whole slew of interventions that help to improve condom use in infected and uninfected populations. Now, one thing that the behavioral science world has to get over is the special package, right? It's a farce. So we have, if you go to like the CDC's, Debbie website, you're going to find, I don't know, 40 or 50 or 60, I don't know, of these packages, right? I got 2 of them, right? They could have 2 or 3. They're more alike than they are different. It doesn't really matter what game you play when you teach HIV education facts. John Jamat's basketball game is just as good as my people card sort. I mean, it's just silly. So you can distill down, as Mary Jane Rothman Boris has done a long, long time ago, you can distill down the evidence-based interventions into principles and common factors. That's what needs to be implemented in the clinic base. And this is killing us. I'm going to tell you why. Because I was on a conference call with a bunch of people like last week. And Mike Cohen says on this conference call, he says, this is confidential information, but Colin says this to David Holtgrave. Won't leave this room, right? Colin says this to David Holtgrave. Holtgrave talks about 12 interventions that have been done with people living with HIV that reduce HIV infections. These 12, and a couple more, right? And David's going through, you know, how these things are working, they're cost effective. Colin says it's the past. It is. Colin will say, he didn't say this, he said it's the past. What he would say, though, is no one's going to take healthy relationships, a perfectly reasonable intervention that is 5 sessions in group that has really demonstrated, I thought, pretty convincing effects when we tested it. No one's going to implement that in a clinic setting. I think it's true. Some people did in Southwest Arizona, but I don't think it's not scalable. It's irrelevant. The principles, what happened in healthy relationships was no different than these other ones. And some of these were in one-on-one counseling sessions. So unless you're talking about just dispensing pills from a vending machine, these principles can be implemented in a clinical setting as long as there is what Jeff Kelly used to call the human contact. As long as there's a provider talking to the patient, you can do these interventions. The group is irrelevant. Well, the group actually has some effect, but you can replace it with the influence of a provider. Right? So it's silly for us as behavioral scientists to say if you implement healthy relationships, you can get an effect. You have to dedicate your resources to that. We're shooting ourselves by doing that. We have to now take the technologies and the principles and the common factors that have been demonstrated effective and make them work in the clinic setting. So we should learn from our past mistakes. We don't seem to be good at that with other biomedical technologies that have been somewhat successful. I think that condoms have not been successful. I think clean needles have been successful. And I think testing and counseling is successful. And we need to get back to a policy when people are tested, they are counseled. Project Respect worked. I don't know why we've abandoned Project Respect. Treatment as prevention offers new exciting opportunities, and I think what many of us are afraid of is that these opportunities could be just another missed opportunity in HIV prevention. And another really piece of good news for the behavioral sciences is, I was on a conference call last week with Mike Cohen and David Holtgrave. That's like really good news. That wouldn't have happened 5, 6 years ago, 4 years ago. This is definitely a different era, and the power structure in HIV prevention knows this, and they're looking for answers from us because they know that people have to take the pills, and they have to be virally suppressed, and they have to avoid co-occurring genital tract inflammation. So thank you very much. I probably talked too long. It's my nature. Happy to answer any questions.